Thank you very much for the introduction. And indeed, I have to say that I'm working on my Swedish, but the most useful word that I learned so far was Systembolaget. So not very helpful today, I would say. I'm happy to be here, and thank you for the organizing committee to invite me to talk to you about transfer and transition of young persons with chronic disease. Quite often I'm getting the question, how comes that transfer and transition is such a hot topic right now? Well, the answer is in fact easy. The answer can be found in epidemiology. When you look at epidemiological studies, you see that up to 40% of children and adolescents do have one or another type of chronic condition. Admittedly, also very mild conditions, very benign conditions are included in these 40%. But still, these are people that need one or another kind of healthcare. And if you know that more than 90% of these people nowadays can reach adulthood, then you can imagine that their healthcare needs are changing over time. And that means that we need to provide and we need to think about chronic disease management from a life cycle perspective. And then transfer and transition becomes a very pertinent aspect. In the presentation of today, I'd like to address some topics. And some of these topics have to do with the development of the adolescent, and other topics have to do with the evidence base that we have so far. What do we know from research? What do we don't know so far? And indeed, let's have a closer look at the development of the adolescent first. We all know that during puberty, during adolescence, the individual is going through a lot of changes, a lot of physical changes, and we don't have to elaborate on that today. But what is less understood is what are the changes that are going on in the brain during that time. And it was in the 90s that there was a group of American researchers that were putting young persons in an MRI to look at the functioning of the brain. And they did a comparison on what is the developmental status before puberty, before the adolescence is really starting, and what is the developmental status of the brain after the adolescence. And it was found that there are two main zones in the brains that are developed the most during this period. And the first zone is indicated here in purple, and it's the prefrontal cortex, and the other zone is the limbic system. You probably know that the limbic system is actually, that's our driver. That's the driver for emotion, the driver for behavior, the driver for motivation. The prefrontal cortex, on the other hand, that's our control mechanism. That is controlling our behavior. That is working in terms of planned decision making. What is the tricky thing here is that the development of these two zones are not going parallel with each other. The limbic system is developing faster than the prefrontal cortex. This means that the drivers are developing faster than the controlling mechanisms. And that's important to understand adolescents and to understand their behavior. And it's due to this imbalance between the drivers and the controlling that Lawrence Steinberg, professor in adolescent health, one day said a teenager's brain has a well-developed accelerator but only a partly developed brain. And that makes sense when you look at adolescents and when you look at their behavior. Look at this. This is an overview of health risk behaviors that is coming from the Youth Health Risk Behavior Survey 2011. This survey is done annually. And 70% ever drank alcohol, almost half ever had sex. This is not so troublesome, I would say. But also almost half ever smoked. 1/4 rode with a drinking driver, bullied on school property, considered suicide, physically active 0 days. So you see indeed that more risk factors are emerging when a child is turning into adolescence. And now we know that the development in the brain can trigger this. There is some good news. This Youth Health Risk Behavior Survey is done annually, like I said. And if you look at the data from the beginning of the 90s until 2013, you see a steady decrease of health risk behaviors. So this means that adolescents nowadays present with less risk behaviors than, let's say, 25 years ago. This is good news. However, there is also some troublesome news. This is coming from a study from Switzerland, and they are doing studies in people with chronic conditions and compare that with people without any chronic condition, being the healthy population. And consistently they found that people with a chronic condition tend to have worse health risk behaviors than healthy people. And that is indeed troublesome. It is seen in terms of smoking, cannabis use, illegal drug use, early sexual intercourse, eating disorder, violent acts, and antisocial acts. And even if it is corrected for age, gender, academic track, parents' education, health perception, and depression, still then you see differences between people with a chronic condition who are doing worse than the general population. We need to know this, and we need to take this up, because this is our responsibility. The WHO made a campaign and a brochure on healthy behaviors of adolescents. And indeed it is known that the behavior throughout the adolescence is a predictor for behavior later on in life. And therefore we need to make sure, we need to pick this up and work with these individuals trying to improve their behaviors. Because doing so, we start in adolescence, and this makes healthy adults. There is another fascinating observation that can be made, and it has to do with the mismatch between biological development and psychosocial maturation. When we go back 200 years and further, you could observe that there was a kind of a balance between the biological development expressed by menarche here and the psychosocial maturation. However, since then, these two developments grew apart. And nowadays, we see that indeed the biological development is starting earlier, but the psychosocial maturation is postponed and postponed. This led some people in launching the concept of emerging adulthood. The decisions that are typical for adult life, like being married, starting a job, and so on, all these decisions are postponed by people. Yeah? They stay at home, they live with their parents as long as they can, they keep on additional studies to postpone, start working, and so on, and so on. This means when we are talking about transition, we are not only talking about the transition, or no longer talking about the transition from adolescence to adulthood, but rather from adolescence to emerging adulthood, and later from emerging adulthood to adulthood. When we are talking about transition, we need to make sure that we know what we are talking about, and therefore some definitions are important. In the literature, you will find a plethora of definitions, and quite often they do have different aspects. On the other hand, you can also find a lot of commonalities in these definitions. And this is actually a summary of the commonalities, the common ground in the different definitions. Transitions are passages from one life phase, physical condition or social role to another, resulting in a temporarily disconnectedness of the normal way of living, which demands an adjustment of the patient and the environment. This is true for all transitions in life. This can be true for becoming a mother or a father. This can be true for changing professional roles, for instance, retiring or becoming the chief of the department. This is also true for transitions in healthcare. So when we are talking about transitions, this is the common ground in the definitions that you can find. Another intriguing element is important to bear in mind is the following. A child is typically cared for in a pediatric care environment. But they come to a certain age that this pediatric environment is no longer deemed appropriate for these young persons. And at that moment, the transfer of care to an adult-focused setting is recommended. Here you hear the term transfer. Transfer and transition are two terms that quite often used interchangeably, but this is not correct. These are related terms, but they do have a different meaning. So, in terms of healthcare for young people with a chronic condition, transition can be defined as the process by which adolescents and young adults with chronic childhood illnesses are prepared to take charge of their lives and their health in adulthood. It's a preparatory process. The transfer, on the other hand, it defines an event or series of events through which the adolescents and young adults with chronic physical and medical conditions move their care from pediatric to an adult healthcare environment. Transition is preparing, it's the process. Transfer is moving from one setting to the other. And it's extremely important that you know this difference, because then you are sure that you're communicating and talking about the same when you're talking with colleagues. What is the evidence base? What do we know from research so far? And when researchers are looking at evidence, we need to look at what has been written, what has been investigated, but also what is the value, what is the strength, the empirical strength of what has been investigated. And for this, we are typically using this pyramid. And this pyramid reflects the different levels of evidence. And the lower the base of the pyramid is actually the level of evidence with the least value, the least strength. The top of the pyramid comprises randomized controlled trials and systematic reviews and meta-analysis, comprises the strongest level of evidence. It was around 2010 that Deborah Hilderson, my then PhD student, did a literature search. And she searched the literature from 1990 to 2009, comprising the issue of transfer and transition. Overall, she identified 217 articles. These 217 articles could be categorized according to this pyramid, and she found that more than half of it was level 4 evidence. And this is editorials, expert opinion, case series, and case reports. So this means that more than half of the evidence is at the lowest level of empirical strength. 42% of the articles was at level 3, being cohort studies and case control studies. 5% was at level 2, and there were no randomized controlled trials at that time. So in terms of the effectiveness of transition, we didn't know anything. Of course, we are talking here about a search until 2009. It's almost 10 years ago. We need an update. We need a modern view on this pyramid. We need a more contemporary view on this pyramid. And that's the reason why a group of our PhD students and postdoc is currently doing an update of this review. And the protocol of this review has been published. And the update is still in progress. We hope that we are able to report on the results by the end of this year. But so far I can say that they conducted a search from 1990 to 2015 and they found 1,000 articles. So can you imagine on this phase of 6 additional years that 750 articles on transition and transfer has been published. So yes, it is a hot topic. Yes, more and more people are interested in this. And in that same period of these 6 years, there were some randomized control trials that have been undertaken. And that's good, because this has allowed some people to undertake a Cochrane review. And this Cochrane review was published in 2016, and these investigators found that there were, at that time, 4 controlled trials on transition. One included patients with spina bifida, one on congenital heart disease, one on diabetes, one had a mix of different chronic conditions. The follow-up of these patients were 4 to 12 months, but overall these 4 randomized controlled trials together included only 238 patients all over. So still not very extensive studies. And different outcomes were investigated. The main conclusion of this Cochrane review was that, in fact, we cannot draw firm conclusions on the effectiveness. Therefore, it is too early, and further research is needed, and probably will also change our view on the impact of transition. So we need to have more randomized controlled trials on transition to get a better understanding of what is working and how. But if we do not only look at randomized controlled trials, but also at the level 2 evidence or level 3 evidence, then another review is also relevant. This is a review published in 2011, and it comprised 10 pre, post, and comparative studies. Most of these studies were conducted in diabetes patients, one in cystic fibrosis, one in transplantation. Also here, small samples, and most of the outcomes were intermediate outcomes. The main finding of this is that patient education program and joint pediatric adult clinics as services can not do, because it does not allow to draw causal relationships, it can improve the outcomes in patients with type 1 diabetes. And this is because 80%, 8 out of the 10 studies were conducted in diabetes patients. It is not generalizable to other conditions. So this means that the evidence based on transition is still very weak. We need to do something about that. Okay, let me dig a bit deeper into the issue of transfer. And remember, from the definition, transfer has to do with going from one setting to the other, going from pediatrics to adult care. And this transfer is not always successful. We know that there are people that are not successfully going to adult care. And in the literature, different terms are used in this respect. You sometimes read about unsuccessful transfer, or care gaps, or lapses of care, or loss to follow-up. To a certain extent, this is raising some ambiguity in our understanding, because is care gap, is that the same as lapses of care, and to what extent is this different from loss to follow-up? All this kind of conceptual obscurity needs to be sorted out. However, what we know so far is that some populations really do have a big problem with this kind of discontinuity of care. And let's have a closer look. For instance, if you look at all the studies in diabetes patients who were looking at continuity of care around the age of the transition, so in the adolescence period, And we take all these studies together and we calculate a mean percentage of people that were having discontinuity of care. Then it was 24%. This means that 1/4 of the diabetes patients did not get proper adult care. When you look at other people with other endocrine disorders, such as adrenal disorders, there you see this discontinuity of care occurred in 34%. People with rheumatic disorders, the median was 41%. And when you looked at people with heart condition, the median score was 42%. So looking at all the conditions and comparing these conditions, the problem appears to be the highest in people with heart disease. We don't know how this comes. Further investigation is needed for this. But this is a median score that you see here. When you look at the scores, at the prevalence data in the different studies, you see a wide range. For instance, in congenital heart disease, the lowest prevalence is 7%, compared to 76% in one study. This is huge. And how can we explain this? I come back to that later on. Of course, we need to look for risk factors. What triggers a person not keeping up the follow-up that is required? And it was in 2006 that Eva Gosses, my postdoctoral fellow, she published a paper in Pediatrics where she did a literature review and kind of elaborated on the different risk factors. Risk factors were living independently, male gender, lower family income, travel distance to the clinic, milder disease severity, fewer pediatric outpatient visits in pre-transfer period, non-university hospital, childhood hospitalizations, and missed appointments. There were also some protective factors. And these protective factors were presence of comorbidity, written referral, good early attenders, greater independence in attending the appointments, perceived need for specialized care, self-efficacy, no substance use, and adherence to medication. This kind of overview is interesting because it helps us to see what can we do about this. For instance, if you have a closer look at this risk factor and these protective factors, it is clear this is something that is, for instance, taken up in transition programs. Transition programs may play a role in avoiding discontinuity of care. I have to admit, we don't have evidence, hard evidence to support this yet, but to stimulate the scientific community, I wrote this short report some years ago, in the meantime 10 years ago, that the implementation of transition programs can prevent it. We do not know if they do prevent, but it can prevent it. It has the potential. And when you look at the risk factors, that's the kind of a proof of concept for using transition programs in this matter. But transition programs are pretty extensive, and Evalena will talk about this more in the next presentation. But there are also easier interventions that can be used. For instance, let's look at the issue of missed appointments. Missed appointments can be reduced by using SMS reminder system. And we did a study on this in Leuven, where we used an SMS reminder system for people coming to the outpatient clinic for congenital heart disease. And we had a missed appointment rate of 5.3% in those people who received an SMS reminder 1 week before the scheduled appointment. We compared this with the group of people that did not get the SMS reminder because we didn't have a telephone number or other reasons. And there the missed appointment rate was 12.6%. We also compared this missed appointment rate within a historical cohort in the time that we were not using SMS reminders yet, and there was a missed appointment rate of 8%. So it shows that SMS reminders may play a role in reducing the missed appointments. And due to that, we can keep people into the system. Think back of the risk factors that I just was explaining. All of them are investigated, all of them are at a patient level. So today we have a rather good view on what are patient factors that play a role in discontinuity of care. We don't have a clue on what hospital factors may play a role. And you can imagine that having a transition program, yes or no, or working with a common medical file in pediatric care and in adult care, having a formal transfer from pediatrics to adult care, all are factors that may help to facilitate this continuity of care. So this kind of hospital-related factors, we should get an idea on what plays a role here. Same is true for healthcare system factors. Is the problem bigger or less problematic here in Sweden than in other countries? And why is this? Are there certain aspects in the healthcare system that is protective or that triggers a risk? And this is important to inform healthcare policymakers and our administrators. So this means, and that's a plea for people doing research in this matter, when we are looking at discontinuity of care, we need to look upon this at the three levels. First, patient level, second, hospital level, and third, healthcare system level. This is precisely what we are currently doing in a study that is called Adolescence. And again, Eva-Lena will talk about this more in the next presentation. This is a study that is conducted here in Sweden in collaboration with South Africa and Belgium. So, talking about the discontinuity of care and the transfer of care. I sometimes get the question, when do we in fact need to transfer the patients? And that's an intriguing and an interesting question. When do we need to transfer? What is the optimal time? What is the optimal age to do so? Well, I've tried to look at the situation here in the Nordics. And please correct me if I'm wrong. But as I understood was that the age of transfer here in Sweden mainly is 18 years of age. In Norway, it was 16 years of age, and as far as I understood, they have moved it up to 19 years of age right now. In Finland, it is also 16 years of age, but they tend to postpone it a little bit. Same could be observed in Denmark, 16 years, 16 and a half, but they tend to postpone it if possible. The country where I come from, people are transferred mainly at the age of 16. And when you look at, for instance, the United States, there people are transferred at the age of 21. And arguments that you hear for this, let's say, late transfer is often that, yeah, but we have to work on their maturity, they need to be ready, they need to have the skills, and that's not possible before the age of 21. I'm pretty critical about this kind of arguments. And the reason is as follows. You are able to get a license as a pilot as of the age of 17. In the United States, you can have a driving license at the age of 16. In some states, you can buy a gun at the age of 14. And for having a gun and managing a gun, there is no age limit. How is it possible that people are not able to manage their condition and their health before the age of 21 if they are able to do all the other things? So I think we should bring things into perspective as well. When you look at the recommendations that are published, it is indicated that there should be a flexible policy on the timing of transfer based on chronological age of the patient, but also patient's level of developmental maturity or the assessment of the readiness to transfer. And that's true, I agree with this. However, if this is becoming an argument to keep the patients as long as possible in pediatric care, then I think it becomes problematic. And then I rather would plead for there should be a fixed age for the transfer of care. And of course you need to fix this age based on the developmental status of patients, but also based on the capacity of pediatric and adult-focused programs. For instance, our pediatric cardiologist in Leuven transfer the patients at the age of 16 because they say we are having so much work and we need to focus on our core business being the diagnosis and early treatment of children with heart diseases. So the sooner they can go to adult care, the better it is for us, so we have our hands free to keep on taking care of our core business. That was transfer. Now let's look at transition. Remember when I was talking about the Cochrane review, that the conclusion of this Cochrane was that no conclusion could be drawn. And that's in fact the reason why we said with our research group, we need to do something about it. We need to contribute to the current body of knowledge. And that is the reason why we started the Stepstones project. And Stepstone stands for Swedish Transition Effects Project, supporting teenagers with chronic medical conditions. And again, Eva-Lena in her talk, she will address this more in depth. Stepstones is trying to find evidence for the effectiveness of transition programs. And when you look at the aims of transition programs, then there are two papers that could be helpful. And one is the results of an international Delphi study conducted by J.C. Suris and Christine Acre in Switzerland. They brought an international Delphi panel together and they looked at what are key indicators for transition. And this is the list that finally was retained. Number one criterion, according to this international Delphi panel, patients not lost to follow-up. Attending scheduled visits in adult care. Patients building a trusting relationship with adult providers, and so on. And JC, after this study, JC kind of said it was surprising that this list came up, because when you're talking about transition, you would rather think about self-management, quality of life, being able to manage your health and your health care. The intriguing thing was that a few months after the paper from J.C. Suris and Christina Acre was published, an American consortium published a kind of similar paper where they also did a Delphi study among American researchers and clinicians, and they found this. Number one was achieving optimal quality of life, self-managing the own condition, understanding the characteristics and complications, and so on. So this was more in line with what JC expected from his survey. In fact, both of these papers can be informative for us to decide what are the goals of a transition program. Also, when you are doing research, these papers can help you to decide what are the outcomes that we should target in our studies. And indeed, when we were talking about and preparing the Stepstones project, we were thinking on, couldn't we go for this? Could we take quality of life as a primary outcome, for instance? And it would make sense based on this. However, you need to know what the status is in the particular population that you target. And from a Danish group who did a meta-analysis, we learned that the quality of life in adolescents and young adults with congenital heart disease is not reduced. So it doesn't make any sense that we are taking quality of life as an outcome in transition program if this is not a problem. We will not address a non-phenomenon. And indeed, it is clearly stated that the quality of life from the different studies it was not necessarily reduced. So quality of life, according to what we learned here, is not an optimal outcome to taken up in effectiveness studies of transition programs. When you talk about outcomes, you also need to be aware on how distal are your outcomes. For instance, you could say, with our program, we try to reduce long-term complications, let's say, in adult life. It will take you some decades to collect all these data, and you will not get funding for these decades to do this study. So this means that if you want to do an effectiveness study, you should not target the distal outcomes first, you should rather go for proximal outcomes and take that up as primary outcomes in your study. And of course, follow-up studies of the trial can be targeted at distal outcomes. This was about the outcomes and the goals of transition programs. What about the content of the transition programs? And to a certain extent, different programs do have different components. But what is really critical that should be a part of a sound and comprehensive transition program is the basic principle of adolescent health and the adolescent health interview. And HEADS is the abbreviation for home, education, activities, diet, drugs, depression, sex, and safety. And in fact, in all adolescent health interviews, this should be targeted. Also, transition programs should take this up, because otherwise you are missing a big part of what adolescent health is all about. Let me come to the conclusions. Adolescents with chronic conditions form a large group, up to 40% of the population, and this group of young persons with a chronic condition do have specific characteristics and specific needs. Transfer and transition are two distinct but interrelated concepts. Hard evidence on the effectiveness of transition programs is scarce. It is growing, but still we need more research. And with Stepstones and adolescency, we try to contribute to this body of knowledge. Interventions to avoid care gaps should be implemented, and it can be complex interventions such as a transition program, but there is also low-hanging fruit. For instance, the SMS reminder system that can be helpful in this matter. Proximal and distal outcomes ought to be defined for the different conditions. If your quality of life of your population is good, don't take that as a primary outcome. And finally, the adolescent health interview, the HEADS, should be in our head because it is a critical component of transitional care. Thank you so much.